Well, thank you very much. I'm happy to be here. Something that I enjoy talking about. So, yes, it's time, but it's time that I think is valuable to use and to be able to talk about the things that we're going to talk about tonight. So, our focus tonight, we're going to talk about erectile dysfunction and stress urinary incontinence as they relate to men's health. There's a couple slides here that everybody can take a second if they happen to have their a camera or their smartphone nearby. You can scan these QR codes and get a little bit more information on some of the things that I'll talk about tonight, but then some even more information that I won't be necessarily talking about, but can help you in your learning and or journey through either erectile dysfunction or urinary incontinence. So if you want to, I'll give a second here to for anybody to scan this code if they want. There should be a link. Usually when you scan your phone, you'll get a little link that'll pop up at the bottom, and sometimes you click on that link and it'll take you to this website here, edcure.org. If you also look at, if you lose this or can't figure it out and you go to our website for our practice and look up my name, you'll also find a link to a website that'll have this same or similar information on it. So if for some reason you lose it or can't get it to work on your phone, you can check on our website there. And so similar here, this another code that you can scan to review any information regarding incontinence. So I'll leave this here for just a little bit and give time for people to take a look at it. Okay, well, just some brief information about myself. I'm a urologist here at Urology Associates. I primarily work down in Franklin at the Cool Springs and the Franklin office. I used to work at the University of Alabama at Birmingham, where I was a associate professor before 7 years before coming back home to Nashville. It looks a lot different since I was last here, but it's good to be back home and be near family. I trained at the University of Tennessee in Memphis, and then I did my residency at the University of North Carolina. And then I did a fellowship in genitourinary cancer survivorship at Duke, which was nice because I didn't have to move for fellowship. I just went to a different color blue. But that fellowship specialized in a lot of what I'm going to talk about tonight. And my focus was on dealing with the complications of cancer treatment. And some of you watching tonight, I'm sure, have dealt with that, and that's why you're here tonight. So we'll talk a little bit more about all of these things here. So first, I want to focus on erectile dysfunction and really just a quick brief overview that many of you may already know. What does erectile dysfunction mean? It really means the inability to achieve or maintain an erection firm enough to have sexual intercourse. So for some people, that may mean they can get some erection and then they lose it quickly. For others, it may mean they never get a penis that's erect as they want it to be. The I think thing that people don't fully understand about erectile dysfunction, and I think we do a better job about talking about it as a society, if you will, than maybe we did even when I was going through training 15 years ago, or that a lot of men suffer from erectile dysfunction. So about 1 in 5 American men will have some erectile dysfunction in their lifetime. There was actually a big study that was done in Framingham, Massachusetts, where they followed men, and more than just men, but for many decades, to see various health determinants as people got older. And they surveyed these men, and 40% of men in their 40s had erectile dysfunction, whether even if it was just some mild form, about 40% of men in their 40s, and it got higher as they got older. So we think, I don't know, is 40 to the new 60 maybe, but it's still not uncommon for us to see some erectile dysfunction even developing in 40-year-olds. And it affects about 40 million American men. If we're half the population, then that's a pretty high percentage of American men that are suffering from erectile dysfunction. The point really being is, those of you who are watching are not alone. So how does erection work? And this will come into play when we talk about what the things that we do to help fix it. Well, with arousal, there are some nerves that go to the penis. And what these nerves do is they relax the blood vessels that go into the prostate. So if you can see my mouse cursor here, then what you can see are these veins and arteries here in the center part of these two circles. And when those nerves relax the blood vessels here, the blood fills up into the penis, and that's what makes it rigid or hard. And then those arteries, as they fill up with the blood, they squeeze or compress these blue veins that are on the edge. And so that's what keeps the blood flow in. When you are done with your erection, say done with intercourse, then that nerve signal gets reversed. And what happens is that blood flow can then flow out because the arteries aren't as full and relaxed as they were before. The main causes of erectile dysfunction are things then that are going to affect that blood flow. So as you see here, the top three causes are vascular causes. So that's blood flow causes. Diabetes is second, and then side effects from medications, often which are being used to treat some sort of blood flow issue, say high blood pressure or congestive heart failure or other heart diseases. They can cause erectile dysfunction by their effect that they have on blood flow. So a lot of times when people are coming in to me, they're asking, why do I have this? And it's like, well, it's usually a blood flow problem. Diabetes, unfortunately, can double team the penis because not only does it affect the blood flow, it also affects nerves. So many of you who have diabetes or maybe have heard of it, you hear of something called peripheral neuropathy, which is a nerve issue that diabetics can have in their fingers and toes. Well, the same thing happens to the penis. You get a neuropathy or you get nerve damage, and that impacts that nerve signal that helps you get an erection. Quite commonly see it as a result of prostate cancer treatment, where more often than not, it then becomes a nerve issue because the nerves that go to the penis run right beside the prostate. The thing we know about erectile dysfunction is that it has a significant negative impact on health-related quality of life. Certainly, and you could argue a little bit in some of the slides that we're going to see here in a second that erectile dysfunction doesn't portend a bad quantity of life, but it certainly can impact people's quality of life. And we see that, and I deal with that all the time in the office. Now, I think you could argue a little bit that erectile dysfunction probably does impact people's quantity of life, and we'll review that here in a second. But for the association between erectile dysfunction and diabetes, like I said, is multifactorial. So not only is it hurting nerves, it's also hurting arteries. The bad thing about that is that we tend to see that diabetic patients are less responsive to some of the pills that we give. So your Viagras, your Cialises, your Levitras, they're working on blood flow, but because the impact can also be on nerves, you may not see the same response as someone who doesn't have diabetes. We can also see that erectile dysfunction can be a precursor of diabetes. I can tell you that many times I've had healthy men come see me. They say there's nothing wrong with them, but they have erectile dysfunction. And it's like, well, something is causing your erectile dysfunction. You check their blood work, and I've diagnosed quite a few people with diabetes, and they didn't know they had it because they never went to the doctor and eventually made it because of their erectile dysfunction. So as I mentioned earlier, diabetes affects nerves and blood vessels. So we can see it cause this peripheral neuropathy, which I mentioned. And unfortunately, diabetes accelerates damage to the lining of these arteries that cause people or that help people have erections. And some of those pills that we give people may not be as effective in these cases. The other things that can worsen ED in men with diabetes would be the longer you've had diabetes, the worse it makes your erectile dysfunction because there's more time for that diabetes to have injured things. Older age will do it. Poorly controlled diabetes will do it. Many of you who have it can assess this with your hemoglobin A1C. When you talk with your endocrinologist or primary care doctor, that number helps give us a bigger, longer picture of how well controlled your diabetes is. Vascular disease, diuretics, which people take for high blood pressure, and heart disease can also increase erectile dysfunction. Now, I mentioned before talking about quality versus quantity of life. Well, it is well established that erectile dysfunction can be a precursor for coronary artery disease. And in fact, it's been shown to be an independent risk factor for future heart-related events. So those of you who are, maybe you're on the younger side and consider yourself generally healthy, well, if you're walking into our office or frankly anyone's office with erectile dysfunction, a lot of times I'm asking, hey, do you have a primary care doctor? Have you had an EKG? Have you had that checked out, to make sure that this isn't a harbinger of something more severe? And in fact, we can, if they ask coronary artery disease patients, hey, do you have erectile dysfunction? Almost 70% of them would say, yeah, I have. And it happened before I showed up with my heart problem. So if you look at some anatomy or representations of anatomy, if you will, for the size of arteries in the body. So we see here on the far left, the penile artery. This is the LAD, they call it, or some people have heard the widowmaker. This is the one when it gets clogged is the one that can kill you if, this gets completely clogged off. You see the penile artery is smaller than that artery. And then you have your internal carotid artery, which is the one in your neck that goes up to your brain. And then we have our femoral artery in our leg. And, you can see here, this is the size of the artery that we're dealing with. So you can see why having some clogging or blockage here may impact what can go on in your heart or even be a precursor to it because it's a little bit smaller lumen. Things that we know that can help improve erectile dysfunction. Well, unfortunately, it's the things that are all, that we all know we should do, but that are sometimes hard to do. And that's eat right and exercise. When I say eat right, there are a lot of diets out there. There's DASH diets, there's American Heart Association diets. There are Mediterranean diets. Really, all of these are going to, generally speaking, be good for erectile dysfunction. When we talk about exercise or physical activity, what we mean is aerobic exercise. So that means something where you're getting your heart rate up and you're keeping your heart rate up consistently. That's going to be something like running or a really brisk walk or the treadmill or bicycling. It's less so going to the gym and lifting weights. That's more of an anaerobic exercise. Think sprinting, a 100-meter dash or doing the bench press or something. That stuff is good for you in a lot of ways. But when we think about erections, we want more of the aerobic activity. Certainly weight loss is good. Smoking, significant factor that will damage those little tiny blood vessels that we saw earlier. And then, I don't know, life seems more stressful a lot of times over the last 3-4 years than it was 15 years ago. So, things that we can all do to reduce our stress levels can certainly impact our erectile function. Now, how about low testosterone? See a lot of men coming into the office asking about this. Well, testosterone is necessary to have erections. Low testosterone is going to be more common in men who are obese, have diabetes, have high blood pressure or prostate diseases, or those with asthma or COPD. And if you look at some studies, it looked about 4 in 10 men. So if you look at 40% of those men in their 40s, just like we saw with ED earlier, can have a low testosterone, and that only tends to get worse as we get older. Some of that is a natural component of aging, but we know from some studies that testosterone replacement therapy can improve erections. There's a lot of different ways to replace testosterone, and that's a little bit beyond the scope of what I'm here to talk about tonight. There are a million ways to raise your testosterone. The main takeaway you could take away from tonight is you're probably wasting your time and money if you're going to a low T center or low T clinic or a quote unquote men's clinic that isn't full of urologists at a urologist practice. You're probably just getting a little bit bamboozled, really, from your wallet. So go see your urologist, go see your primary care doctor, whoever it may be, and have us address your testosterone. Now, how about prostate cancer treatment? I'm sure some of you watching tonight are here because of prostate cancer treatment. Well, the general main reason that men can have trouble with erections after prostate cancer treatment is the nerves that run right alongside our prostate, specifically these ones that we see down here, are the ones that then run along our sphincter muscle, which is what helps us stay dry and maintain continence. They run right alongside all of that and then go down and out to the penis. So when we're cutting this prostate out, we have to essentially peel or shave these nerves off in order to keep a guy having good erections. And depending on the type of cancer you had, how aggressive it is, you may or may not have gotten those nerves spared. And then there are blood vessels that come in the area as well that sometimes have to be taken in order to get the prostate out and cure the cancer. And unfortunately, erectile dysfunction can be a side effect from it. Very common for it to be an issue right after surgery. Guys tend to improve as time goes by after prostate surgery, but certainly not everyone does. This slide here shows that sexual dysfunction impacts about 25 to 75% of men. I usually tell a guy about 2/3 of men will have some impact on their erectile dysfunction or erectile function afterwards. And oftentimes at the minimum, guys will need pills to help get back to where they were beforehand. And then 1/3 of guys aren't going to get back to where they were beforehand, even with pills. So that's where some of the other things that we'll talk about tonight come in handy. As I mentioned before, anything involving nerves takes time to heal. It can take a year for erectile dysfunction to improve after surgery. We see the same thing, unfortunately, in men. Radiation tends to not have that immediate loss of erectile dysfunction, which we then see a return of after surgery. Radiation is somewhat the opposite, a little bit of initial hit that then slowly gets worse as time goes by. And then when things kind of settle out all in the end after surgery or radiation, the erectile dysfunction rates tend to be pretty similar after both of them. Another condition that some of you may be suffering from is Peyronie's disease. This is the commercial you see on TV with the bent carrot. But this is a scar tissue condition that can happen. Oftentimes we don't know why, but what it can do is cause guys to have difficulty with erections, either getting them, maintaining them, or curvature impacting the ability to penetrate. There are a lot of different treatment options for Peyronie's disease, which again are a little bit out of what I'm going to talk about tonight. There's a medication called Xiaflex, which is what that commercial is for that you see, and we inject it into this scar tissue to try to break up that plaque. There is surgical options for Peyronie's disease. And for guys who suffer with erectile dysfunction and have this curvature, oftentimes the best fix is going to end up being a penile implant because it kills two birds with one stone. And why go through a surgery or injection to treat a curvature when you're done, you still have a problem with ED. So a lot of times in those cases, we'll recommend penile implants. There are some things that you're going to see advertised on TV here on, the shock jock radio that are still considered investigational. Some of these things may change as time goes by. What I can tell you, if some studies have come out on these bottom two things that have really said that they are not particularly helpful, and these were legit good studies. They were done down in Miami. Low intensity extracorporeal shockwave therapy. The literature on this is still investigational. There are some studies that show that it can be helpful for men who have a more mild erectile dysfunction responsive to pills. But you should know you're going to be paying cash. You're going to be paying a lot of cash. And if you do decide to go through with this, you want to make sure that the people who are doing it are using the right machine. I'd say a majority of people are not using the correct machine, and you're wasting your money and throwing it down the drain. But as a whole, it's still considered investigational. When I talk about it with men, very much stress that point. So the options that you may be more familiar with or have heard: medications. These are our Viagra, Cialis, Levitras. Injection medications. For those of you who use this is most commonly what people hear about is called Trimix. There's also medications called Bimix, and then there's a alprostadil, which is a single mix, if you will, that can be injected. There are vacuum erection devices. There are urethral suppositories, and there are penile implants. And we're going to touch a little bit on all of these things tonight. So the oral medications, the PDE5 inhibitors, these are your Viagra, Cialis, Levitras. They work to increase blood flow to the penis. They do this by impacting on a cellular level, getting those arteries to expand and open up so that more blood can go in. They're generally effective for guys who have a more mild to moderate erectile dysfunction. Things I tell people are you want to take them on an empty stomach because especially Viagra or sildenafil, not as much Cialis, they can be impacted by food. And so if you take them with food, they'll delay the absorption of the medication. So the timing can be off for when you think it's going to work. Um, they we tell people not to take them with a lot of alcohol. They can make your blood pressure too low. And you certainly don't want to take them if you're taking any nitrates for chest pain. So nitroglycerin, whether it's under the tongue or patches or creams, you can really lower your blood pressure if you do that. And that can, in a bad way, heart attack kind of bad way. Generally speaking, the risk of that from these medications is incredibly low as long as you're not, taking some of these medications. Common side effects we see from these are headache or facial flushing. Those are hands down the two most common things I see. The good news for these is those side effects tend to get better after you've tried the medication 5 or 6 times. Not uncommon though, as we have highlighted here on the bottom, these don't work forever. The same disease or condition that's causing the blood flow issues, unless you're really aggressively working on it, whether it's diet, exercise, weight loss, high blood pressure, diabetes, whatever, tends to continue to build up as time goes by. So oftentimes these medications will stop working at some point. I'd say probably most commonly what people to go next after the medications don't work is injection therapy. So this is actually think of these as cousins of your Viagra, sildenafil, Levitras that are made at compounding pharmacies. You're not getting this at CVS or Rite Aid, Walgreens. And these medications are then injected directly into those blood-filled spaces that we saw in that slide at the very beginning. And so these medications in the injection are essentially bypassing all the blood vessels ahead of it and the nerves ahead of it that are what causes the issue. And we're just going straight to the source. So nice thing about these is they work right when you want them to work. It's not the kind of thing where you inject and 2 hours later you're ready. You inject it and it's ready right then and there. Downsides to it, you're giving yourself a needle and injecting yourself. Some men find it painful. You can get a prolonged erection with these medications, which can be difficult thing for both provider and patient to deal with. It requires us to do more injections to reverse it. And these medications can be successful, again, depending on the level of erectile dysfunction that someone has. But some men will see that these two will also stop working as time goes by or never work to begin with. And sometimes I see men who, let's say we're going to do a penile implant. If they've been on injection therapy for a long time, you see them develop a lot more scarring in there. And it's probably just the usage of the injection over time. We see that, these work well for a lot of guys, but you also see a lot of guys who come off of this therapy as time goes by. They get tired of having to go to the compounding pharmacy, having to keep it frozen when they travel. What do they do with it? Having it on an ice pack when they're going through the, airport screener, or just the pain from the injections. Vacuum erection device is another treatment that we can use for erectile dysfunction. This is probably fourth, if not fifth, on my list of things that men use the most. It's essentially just like what the picture looks like. You are sliding a pipe over the penis that has a vacuum pump on the end. You either hand pump it or some of them are battery powered, and it creates a vacuum, and that vacuum will then suck or draw blood into the penis. You put a band around the base of the penis to hold that blood in. As you can see somewhat from this picture, it can be helpful for guys getting an erection. And in some cases, I even recommend people use this, actually not in some, in all cases, after a prostatectomy, I recommend guys use this because the simple act of stretching and pulling can help with erectile dysfunction in the long run, but also some shortening that guys complain that they have after prostatectomy. But as far as being the main mechanism by which guys get an erection in the long run, I'd say this is very, far down on the list. Guys tend to complain about this band. They get a little hinging of the penis there, and it's not, down in the deeper part like we might see after, with an implant or with a natural erection. They get the hinging there. And then they sometimes complain that the penis gets a little blue and a little cold, from that band being there. But the nice thing about it, it's not a pill, it's not an injection, it's a one-time cost. You do it in the comfort of your own home, and you're not having to worry about the timing. You again know when it's right. Urethral suppositories are hands down the least likely thing that I see guys use. This is essentially, think of this as a cousin of Trimix or the injection medications, but rather than injecting it into the penis, you're putting it into the urethra. And then what happens is that medication dissolves out into the penis and helps guys get an erection. The problem with these medications in the past have been they're very expensive, they're hard to get, and you have to find the right compounding pharmacy often to do them. The other thing is guys complain a lot with burning with these because you're sticking this suppository in the urethra and they get a lot of urethra burning from the medication. So, this is an option for sure. I actually prescribed a urethral gel to someone last week. So it's not that they don't work or aren't useful. I would say that because of the cost and the burning, these are probably low on the list for medications that I often prescribe, but certainly an option that can help guys. Last but not least is a penile implant. This is another mechanism which we can use to help guys get an erection. This is essentially a hydraulic pump that goes in the penis. So remember on the injection picture and that earlier picture we saw, we have those two blood-filled cylinders that are in the shaft that get hard and fill up with blood. Well, essentially what these do is they replace those blood-filled cylinders with these saltwater flavored cylinders, not flavored, saltwater filled cylinders. And then what we do here is they're connected to a pump, and then there's a reservoir that holds all that salt water. And when you want to get an erection, you pump this pump. It sucks the salt water out of here into the cylinders and gets rigid. Then there's another button on here that you push to then help deflate it, which is what we're seeing here. Nice thing about these, it's a one and done. They're very spontaneous in the sense that you're not worried about, do I need to take this pill 60 minutes before intercourse? Has my medication been frozen? Hold on, honey, I need to go to the bathroom and give myself a shot. You don't have to do this with these. So that's another option that we recommend to people who have trouble with erections. I'm going to talk about them a little bit more just because there are different models that people will read about on that website that's at the beginning too. You might see those there. The three-piece kind that we see here, which is the one that was in the previous slide, is hands down the one that we use the most. This is the device that gets the most rigid. It gets the most flaccid. So in the sense that it gives you the most natural erection and the most flaccidity. So if you're at the Y in the shower, nobody's going to know that you have one of these things in. There is a two-piece device that misses this reservoir here. I can count on one finger the number of times that I've put these in. The reason that we would tend to do these is because, let's say somebody had a very hostile abdomen, meaning it would be a real challenge to get this reservoir into their abdomen, usually because of some surgical history. This is why we might use one of these. Usually I can get one of these in someone's abdomen. So it's not that big a deal. And then there is a malleable implant, and this is different from both of these in that there is no pumping. This is simply two, let's call it solid cylinders in the shaft of the penis. These, I tell patients they're more like a Gumby. Somebody tried to tell me a Gumby the other day was from my generation, even though they were many decades older than me. I said, no, Gumbies are from the 50s or 60s. I looked it up just to prove it. But Gumby, this is more like a Gumby. You just bend it in wherever you want it. So the nice thing about these is they're not mechanical. They can't break or spring a leak. The downside to them is it's kind of like you always have a little bit of a semi-erection because they're harder. There are distinct reasons we might use that implant. And so it's a distant second to the three-piece, but it is, something that I'll end up using a little more than these two-piece ones. So the three-piece penile implant is hands down the most implanted one. We coat these in antibiotics, just like any artificial device you put in the body, whether it's a heart valve or your artificial hip or your knee. Our worst enemy is infection. And so these devices are coated in antibiotics. We do all kinds of other things to prevent infection when we do the surgery as well. But that's the beauty of this device is that it's pre-coated so that we have a very low infection rate when we put these in. Like I mentioned before, most flaccid look, excellent rigidity when it's inflated. It gives you that more natural erection compared to any of those other devices. that I talked about. And for those that are curious, these things have been around for over 45 years. I was thinking they've been around for over 50 years. Some of these original ones were put in the early 70s. So lots and lots of people, have received these throughout the last 5 decades. There's a quick animation here that just shows you briefly how these things work. So we'll get that going here. I'll oftentimes show this to people in the office so they have a general idea of what I'm talking about. But these are the fluid-filled cylinders that we're going to see in the shaft here, pump here, reservoir with the salt water in it. And you can see as you pump it, it's going to draw the salt water out through this pump and then into these cylinders. You'll get rigid or hard. When you're done, there's a little button here that you push, and then it does the opposite, draws the fluid out of the cylinders and back into that reservoir. So the beauty of it is it's ready when you want it to be ready. And when you're done, you're done. There's no worrying about, is my erection going to go down or not? So when we do these procedures, I generally do them outpatient. So you come in and go home same day. It's a small incision either in the scrotum, just below the penis, or just above the penis, right around the pubic bone. You're generally going to do your normal activities the next day because you have to. You're not in the hospital and you got to take care of yourself. And then it's about 4 to 6 weeks before you're able to use the implant in terms of the healing process and waiting for the incisions on the inside to heal up before we get you using it. We get you back to the office and then teach you how to use it. I would generally tell you that for some of the earlier treatments, as far as pills go, a lot of times those are covered by insurance, but the cost I see is still widely variable between what somebody might have to pay for things. Injections, vacuums, the suppositories or intraurethral things, much less commonly see insurance cover those. Those are usually always going to be cash. Implants, highly likely I see those covered. People think that they wouldn't be, but more often than not, well over more often than not, I see that those devices are covered. So these are things that if you're interested, you can always ask us and we can check and figure it out. It's going to be a similar thing for incontinence, which we'll talk about a little bit as well here. These are just a couple of testimonials that y'all can look at as far as some of these patients, who have undergone penile implants. And, what I can generally tell you is that once guys get used to these things, they're very happy because they're not using needles. They're not using pills. They're not worried about, again, is this medication cold? Is it expired? They're not running back and forth to their pharmacy. And so they're usually very happy with it. What about beyond these two gentlemen here? Satisfaction rates are generally very high with penile implants. You're looking in the high 90s of percentage points. Like I mentioned before, they're generally covered by insurance. They are very durable, so they've gone through a lot of revisions since they came out in the 70s. And for the most part, these devices are still functional and alive even 10 years after they've put in. Now, they can break or spring a leak, and then they stop working and we have to fix them. But for the most part, these things are still working after we put them in. And like I mentioned before, these tend to be the most spontaneous and natural ways to get erections. Certainly, there are risks with surgeries, and these are things that I go over with patients, when I see them. Always a risk of infection, always a risk of, we talked about mechanical malfunction of these, or damage to something else around where we're working. And these are things that we would all review if anybody ever came in and was interested in one of these. But as a whole, generally speaking, benefits of these far outweigh any of these risks. So just to summarize, you are not alone. If you were here to learn about erectile dysfunction, there are millions, tens of millions of men who suffer from this. There are a lot of different options that we have on the table. Please see your urologist or your primary care physician to learn about these options so that we can educate you more. Penile implants are a great option. There's plenty more on this website to review. And like I said, you can check out our practice website. And then I have another site you can link to that tells you a lot about these different things as well. So I want to shift gears a little bit to stress incontinence. This will be a little bit shorter than the erectile dysfunction one. But stress urinary incontinence, this is exactly what it sounds like. It's when you do stressful things to your body. That's when you have urinary incontinence. So you're coughing, laughing, lifting, sneezing, bending over, using the axe, the jackhammer, whatever it may be. You do these things that stress your bladder or your sphincter muscles, and that's when you have leakage. It is not common for men to get stress urinary incontinence just spontaneously. It's usually going to happen after some sort of generally surgical procedure or trauma. So the most common things that we might see this after would be prostate surgeries. I see it after pelvic fracture, pelvic trauma, bad motorcycle accidents or car accidents. These can damage the sphincter muscles. We might see it after rectal cancer treatment, where people have undergone chemotherapy, radiation, pelvic surgery to deal with the rectal cancer. This can impact the nerves and things that go to the sphincter muscle. The important thing here, too, is that there are plenty of men who suffer from stress incontinence as well. Sadly, I have too many men that I have operated on for their stress incontinence, and they go, why did somebody not tell me that this existed 4 years ago or 10 years ago? You know, they've been living with this from their complication of whatever. And we have some great options that we'll review tonight, which can help with this. So how does stress incontinence happen? Well, just a quick discussion about how we even hold our urine in. So the bladder is simply our storage for urine. Guys are a little bit different than females because we have a prostate and an external sphincter muscle. These both function to hold the urine in for guys. Women don't have a prostate, so there's not this extra sphincter mechanism. So more commonly, people think about incontinence in women, and that's probably true. We're sort of lucky in some regards in that we have a double sphincter here, if you will. But what commonly happens is that when the prostate is removed, we're left with only this one. And if there's injury to it or damage or doesn't work quite right, that's when guys can get leakage. So this prostate musculature, we don't really control. It always helps hold our urine in. The sphincter muscle, this is the one that we can control. This might be the one when we're running to the bathroom and we've got to go and we're kind of holding it. You know, this is that muscle that you're squeezing here. So in order to pee, you have to relax that muscle, and that's how the urine gets out. Well, commonly that stress incontinence can happen most commonly after prostate cancer surgery. And I'd argue probably that this number is a lot higher in what I see in practice. Right after you've had some sort of prostate cancer surgery, highly common to have leakage. Tends to get better, much like erections as time goes by. But unfortunately, up to 16% of men will still have some incontinence after their prostate cancer surgery a year after treatment. There are other things that do it as well. We mentioned pelvic trauma. We certainly see this after radiation for prostate cancer as well. I see this after, say, TURPs or green light prostate procedures, HOLEPs. These are other types of surgeries that we do for non-cancerous prostate enlargement. And then we also see it in neurologic conditions, so spinal cord injury or spina bifida, things that impact how the spinal cord sends nerves into the bladder can cause stress incontinence as well. Obviously, you can understand how leaking urine can have a big impact on your quality of life. These are probably the people that I see that are the most impacted by their non-cancerous condition, in the sense that they no longer go out, they don't go see their friends. They oftentimes go to church on Sunday and that's it. And especially those guys that are really leaky, they feel stuck at home. And so the sad thing is that they hopefully haven't done that for a long time before they get to the urologist, because it's something that we have a good treatment for. But I see this all the time on how these folks no longer get out and do what they like to do. So as I mentioned before, prostate cancer treatment can lead to stress incontinence. This is that same picture that we saw earlier. So when that prostate gets cut out and removed, we have to sew this urethra back to the bladder. And that's what they're depicting here. So depending on how well this sphincter muscle works can impact your leakage afterwards. There's a lot of things that can impact this: the length of your sphincter, how big your prostate was, nerve sparing. In some cases, we don't really fully understand why some guys get leaky afterwards. But this is why it happens, is because of the trauma that we cause, when we remove the prostate. There are a lot of things that guys can do to help with this. I see a lot of guys who say, I go to the bathroom frequently so that they can try to empty before they have leakage, or guys who self-restrict their fluid intake to try to limit their leakage. Oftentimes, some of you who've had prostate cancer treatment may go to pelvic floor physical therapy and learn Kegel exercises or biofeedback to help better control that sphincter muscle. There are other things, people wear pads, diapers, catheters, and there are external clamps that people can wear as well. I saw somebody last week who said he uses 100 diapers a month. He had another piece of a chart. He was using 140. He was spending tons of money, on pads and diapers. And that was actually one of his complaints, was how much money it was costing him to deal with his leakage. And I see people who still want to travel. They take an extra suitcase, of diapers when they go. And that's something that we fortunately can help with. But again, you can imagine how that can impact someone's quality of life. I got a little ahead of myself here, but yeah, I mean, we can see that when you're spending this much money on pads and diapers, that it can cost you a lot of money in addition to the accidental leakage onto your clothes. See plenty of guys who wear dark pants only because they're worried about leakage in public. And some of these external products get irritating as well. So these are things that we can fortunately improve and help with. I look at this in two lights. There's good news and there's bad news about incontinence. The good news is we have very good options. The bad news is there are no FDA approved pills for incontinence. It's going to take a surgery, generally speaking, to help the continence. So what I would say is the great thing about it, though, is that the surgeries work very well. There are two main procedures that we use to help with incontinence. One of them is a male sling. The other is an artificial urinary sphincter. So a male sling is essentially a little bit of it's a mesh hammock. That's the best way I can describe it, that goes under the urethra. Outpatient procedure, come in and go home same day. You're usually immediately continent in terms of your improvement after the procedure. Very high success rate. I generally quote people about an 80 to 90% improvement in their continence. The beauty of it is it works right away. There's no pumps, there's no moving parts. It's there and you're usually good to go. 92% of the men who've done it would do it again. So like I mentioned before, this is it. It's a little mesh hammock that goes under your urethra. We make a small incision in the below the scrotum. And then we place this through little two poke holes in the groin. And then that incision rests under the urethra here. I'm going to go ahead and answer a question that I'm seeing pop up in the chat. I tend to do these only in men who have post-surgical leakage. I am not a big fan of doing this in men who've had surgery and then radiation, or who have had radiation alone. The reason is the radiation tends to fix and scar everything in place. So if you go put a sling in, the tissue just isn't as mobile and doesn't move like it should, and you just don't get a good outcome after the sling. You tend to be better served by the next thing that we'll talk about. So a sling, I personally tend to reserve for the non-radiated men. I did an informal survey in my prior job one time, asking people all over the country, who uses a sling in radiated patients. It's only about 20% of people did that. I would argue, the number should probably be a little bit lower. So again, satisfaction rate's very high. 92% would do it again. 94% would tell their friends that they ought to do it. The artificial urinary sphincter is the other option that we have. This has been out much longer than the sling. The sting's still been out for over a decade, getting close to two. But the artificial sphincter has been around also since the early 70s. The same guy who helped create this helped develop the penile implant. And this is another solution that we have for guys who are radiated or have a more severe leakage. And that this works a little bit differently. It's not that mesh hammock. It essentially acts as a replacement for your sphincter muscle. So this is also done through a little incision under the scrotum. We put this plastic cuff around it. And then similarly, it's made out of three pieces, a pump and a reservoir, if you will, that helps hold things in. And so this will show you here how this works. And so that reservoir there applies constant pressure to that cuff so that when you're doing physical activity, heavy things, coughing, laughing, sneezing, then your urine is held in place. When you get the urge to go to the bathroom, that's when you pump this pump. And then it opens up this cuff so the fluid comes out. And so it relaxes, and then you can pee through your urethra. And then the nice thing about this is that you don't have to do anything else to get to start working again. It just automatically fills itself back up over the next 60 to 90 seconds. So you pee, you pump it, you pee, you're done, you pull things back up, you go on your merry way. You don't have to do any other pumping of the artificial sphincter. It is also an outpatient procedure, small incision in the under the scrotum and then in the groin area. And then this one, I usually wait 6 weeks before we get you back to using it. So you're not instantly dry like you are with the artificial sphincter, but still give yourself 6 weeks of recovery and then you'll get very dry. I usually quote people also about an 80 to 90% improvement in their leakage. You know, I tell guys every once in a while we get a home run and knock it out of the park and you get completely out of pads and completely dry. I'd say more commonly we get people down to 0 to 1, pad. So that might be that safety pad or protection pad. If you're using a jackhammer, if you are out, swinging a baseball bat, it may not, you may still have that little bit of a squirt. But most people who were using it, they're getting out of diapers or many, many pads. They would gladly take that over what they were doing before. Similarly to the sling, very high satisfaction rates with their devices. I would generally say sling and sphincter patients are probably some of my happiest patients, if not my happiest patients, because of what the impact that it has on their quality of life afterwards. Similar to erectile dysfunction, stress urinary incontinence treatments varies, but I would say more often than not, it is covered by insurance. This is generally a complication of some sort of cancer treatment. Every once in a while, I'll get an insurance denial. And I think it's just because it's what they do to try to keep us from, giving people the care that we think they need and that they want. I send them back a piece of paper and they fix it and it's covered. Usually, I think it's just almost a default for them sometimes. So it's not usually a big problem with continence here. So a couple other folks here who have had good experiences with their incontinence treatment. Again, I would generally say these folks are very happy. Always a little bit of bruising and swelling afterwards that they recover from. But getting out of pull-ups or diapers and being able to go back to doing the things that you like to do are, I think, some of the most rewarding things that I do to help people. And I think, again, some of the happier people that I treat. So the beauty of these two devices, there's nothing external. There's no pads. You're not purchasing things for the rest of your life. You're not packing extra suitcases. Satisfaction rates are very high. And yeah, I'd argue gives people a lot of confidence. I've had some guys that I've treated and they have refused further cancer treatment because they were worried about how it would impact their devices because they make them so much happier. So these are the kind of things that guys really like. Similar to a penile implant, there are always side effects or potential risks to surgery. The good news is these are uncommon. Always a small risk of infection. A sling, I'd argue doesn't really quote unquote fail. An artificial urinary sphincter can break or spring a leak, much like an implant, because it has that salt water that moves through it. There's a small risk of an erosion of the urethra, so that cuff eating a hole in the urethra. If there are reasons that can happen. Sometimes has to do with individual patients and the treatments that they've had for their cancer, say. Rare risk of urinary retention. We see postoperative pain for sure. Always a small risk of infection. Again, very much see the benefits of these outweigh these risks. And a lot of this stuff is reviewed on those sites and on the site that I have as well. And I give handouts to patients who are doing these things that describe these things as well. But very rare that I would tell somebody they're not a candidate for one of these things because of the side effects. So final slide, on the stress incontinence here, we have great options. They're good long-term options. Yes, they are surgery, but they are really good at getting people their quality of life back. So these are some references here that you should be able to take a look at. And I'm happy to take any questions. I see a few over here that I'll go ahead and knock out that I'm seeing on the chat here. As far